she updates about the new DRCRnet studies.
Thank you so much. It's really a pleasure to be here at DRCRnet, and I'm going to talk specifically today about a project we've been doing trying to define strong versus weak response to anti-VEGF treatment for center-involved diabetic macular edema. So I think in some ways a very apt companion piece to the talk that you just heard. Here are my financial disclosures, and the disclosures of the network investigators can be found at DRCRnet. DME, as we all know, is a leading cause of vision loss, despite the fact that we've developed new treatments for this. And although most eyes are treated with anti-VEGF do very, very well, still more than 50% probably don't achieve 20/20 vision or complete resolution of thickening in the studies. So one of the major questions that's arisen in the field is how can we better predict which eyes will respond well to treatment and which ones won't? And this has implications for how we manage and counsel our patients, also has implications for the development of new therapies. Addressing this question has really been limited by the lack of agreement on the definitions of treatment response. We all throw around the terms of incomplete responder, failures, non-responders, but there's not clear definitions as to what these mean in the literature. Now, in the clinical studies, we're often talking about mean change in visual acuity, mean change in central subfield thickness. But these statistics on these continuous outcomes usually describe a population, not an individual. Binary outcomes, including thresholds of letters, gains of 15 or more letters, 10 or more letters, et cetera, are often reported as secondary outcomes. But we've seen over the course of multiple clinical studies now that the likelihood of gaining a certain threshold of letters, 15 or more letters, for example, is highly dependent on the baseline visual acuity. And the relevant outcome for an eye that starts with severe vision loss, let's say 20/80 or worse, is likely different than an eye starting at 20/25. For example, a one-line gain of vision might be great if you're starting with a vision of 20/25, but might not mean as much functionally if you're starting at 20/80. Changes in central subfield thickness are also very dependent on baseline central subfield thickness. So the goal of this network study was to characterize the visual and anatomic outcomes for eyes treated with anti-VEGF for DME. And we really wanted to develop standardized phenotypes of treatment response for future studies, phenotypes that were clinically relevant, applicable to both individuals and populations, stable across cohorts with varying characteristics, and that addressed both functional and structural success. This was an exploratory analysis of data from anti-VEGF groups in our prior DRCR studies, and we included cohorts from Protocol I, treated with ranibizumab, Protocol T, randomized to aflibercept, bevacizumab, or ranibizumab, and Protocol V, treated with aflibercept. The baseline visual acuity of these cohorts differed somewhat in that V had eyes with better vision to start with. The eyes included in this analysis needed to have available vision and CST data at baseline and 24 weeks. So here are the baseline characteristics of the eyes we used, in total 958 eyes. As you can see, mean age or median age was around 60, with a slight predominance of males, generally a Caucasian population. And the visual acuity and the central subfield thickness tended to be a little bit better in the Protocol V patients, unsurprisingly. We first looked at the continuous visual acuity outcomes, and what we did was we divided our groups up into categories of mild, moderate, and severe visual impairment, based generally on tertiles of where they fell. So you can see the mild in blue, the moderate in yellow, and the severe in orange. And mean change in vision over 24 weeks was highly associated with these baseline visual acuity categories, whether you were talking about vision change in letter score or the area under the curve analysis. Eyes with worse baseline vision in the orange were more likely to gain more vision with treatment. So we said, can we develop an outcome that's not quite so dependent on baseline vision? And what we did was we took into account the baseline vision. So we took these three categories, mild, moderate, and severe visual impairment, and we used what we thought were clinically relevant thresholds of gain of 5 or more letters for the mild visual impaired eyes, the gain of 10 or more letters for the moderate eyes, and 15 or more letters for the severely visual impaired eyes. And what we saw was when we used these thresholds for these different categories, all of them ranged from about 50 to maybe a little bit, nearly 60% in these groups. We did something similar for the baseline CST groups. Now, we know that interpretation of CST is dependent on machine and participant sex, so we defined subgroups based on the number of microns above the center-involved DME thresholds that have previously been established in DRCR network studies. And these were sort of mild, moderate, and severe thickening. You could think of it those ways. When we looked at the continuous outcomes, again, the eyes with the most severe retinal thickening in orange had much more improvement in central subfield thickness than the ones in blue, which only started with mild thickening. And once again, we used these categories of retinal thickening at baseline, and we set thresholds of 50 or more micron decrease, 100 or more micron decrease, and 200 or more micron decrease, figures that we thought would be easier to utilize in practice. And these generally were seen in slightly above 50% of each of these groups. Let's talk about across studies. We wanted outcomes that could be used across populations that differed in characteristics. And so we looked both overall and within each study, and we found that the percentages of eyes with strong vision and strong CST response, the sort of extreme responders versus those that had weak response on both visual acuity and CST axes, were fairly constant across our studies, despite the fact that Protocol V had eyes, as I pointed out before, that were milder in disease and had better vision. What about durability over time? So along the horizontal axis here, you can see the 24-week response. And again, I'll focus you on the extreme responders. Those with strong vision and strong anatomic response are seen in the bar on the left. And when you compare the 24-week response to the 2-year response, 104 weeks, you can see that relatively few, less than 10% of them, flipped those extreme categories from strong, strong response to weak, weak response. The same is true if you look at the weak responders, both vision and central subfield thickness early on. Only about 20% of them then continued to have an improved response where they were labeled as strong responders on both categories. We asked the question, is this just due to the number of anti-VEGF injections they're getting? Are the weak responders getting fewer injections? And we found that, in fact, that was not the case. In fact, if anything, the weak responders were probably getting more anti-VEGF in our studies, and this was just due to the way our retreatment algorithms were designed. We took these categorical estimates and we said, we can probably be more precise about this. So we fit equations to estimate the change in vision and central subfield thickness at 24 weeks as a continuous function. These are more precise than the 3 baseline categories that I showed you in the first set of slides here. And strong response was defined as meeting or exceeding the expected values from the regression equations. So we've developed these very specific thresholds of response for visual acuity on the left and central subfield thickness on the right, and these are we've made publicly available. I'll just show you the scatter plots for the model-based phenotypes, both for visual acuity and for central subfield thickness, just with the point that, in general, we expect about 50% to fall above the line and have strong response, and 50% to fall below the line with weak response. When we look at the model-based phenotype and the durability of that phenotype over time, again, this is similar to the graph I showed you, the 24-week response cross-tabbed with the 104-week response. And again, you see that very few eyes that have strong, strong response at 24 weeks then flip into that more extreme category of weak and weak response at 104 weeks. And about 20%, similar to what we saw in the categorical analysis, flip from weak response to very strong response. So we conclude that the development of standardized methods to categorize eyes as having strong versus weak response to anti-VEGF treatment, we hope will be beneficial for future research efforts addressing eyes with DME. These phenotypes might aid efforts to identify targets beyond VEGF for future therapeutic investigations. And for sure, these definitions will be used in our future DRCRnet network pharmacogenetic studies, our artificial intelligence initiatives to predict treatment response, and in other efforts to identify predictive biomarkers in eyes with DME. So anyone who is interested in looking at the models and the specific thresholds, as well as some of the figures I've shown here, is welcome to look. The results were published in Retina a little bit earlier this year, and I'm happy to take questions. Thank you.
Hello.
That's a wonderful talk. We have a question there.
Yes.
Do you have a short question, please?
Thank you very much. I'd like to remind you that on the 5 years extension study, the DRCRnet accepted that there was a failure, and in 2018, they agreed that there were severe flaws in their studies. The mixed focal edema, diffuse edema, traction and non-tractional, ERM, non-ERM, and laser focal and laser diffuse. So just to be careful when you go to a definition or conclusions, because this is, they told this was a big mistake.
Thank you for the comment.
Thank you.
There's a question here.
Thank you very much. Regarding Protocol W, and what would you conclude? Should we wait till worsening of visual acuity or not? Because it was very interesting, our results. So I don't know if you should review the Protocol W, trying to find any connection between them.
Sure. You know, I think the question of when do you start treating with anti-VEGF, and do you treat eyes with non-proliferative disease without diabetic macular edema is a really important one. I think both Protocol W and Panorama showed that although we can reduce the rates of vision-threatening complications by starting treatment earlier, there doesn't appear to be a visual acuity benefit in starting treatment before PDR or center-involved DME with vision loss occur. And in fact, if you just go ahead and you start treating eyes when those complications develop, the visual acuity outcomes really seem pretty good. In my personal practice, I don't tend to treat with anti-VEGF early unless there are extenuating circumstances that make me think in an individual patient it makes sense.
I have a question. Jennifer, you introduced the nice concept that I like of phenotyping DME, correct? And you use visual acuity and CST, correct? Do you think that other biomarkers may be useful to a better definition of the concept of phenotyping, particularly in the future perspective of treatment?
You know, I would welcome the use of new, and the development and the validation of other biomarkers. And Eduardo, I know you're going to talk about DRIL a little bit later, which is near and dear to my heart, certainly. So I think there's a clear and critical need for additional biomarkers that predict treatment response, that predict outcomes in the natural history of the disease. We used visual acuity and CST just because these are so, readily accepted, at least visual acuity from a regulatory standpoint, and CST, so many of our treatment algorithms are based on this. But there's a lot of effort going into data mining the clinical trial data sets that we have now to look at additional structural and functional biomarkers.
Thank you very much for, again, a wonderful talk. And again, we are all in awe of the amazing DRCRnet studies. Fantastic.
You're very kind.
Our next speaker is Professor Naomi Lois from Belfast. She's going to talk about the